Healthcare is changing, and Dr. Nancy RN is here for you. The topics are many, but each program stands on its own with 3 key action points for you to learn. Your guide to a healthier you in a changing world. Dr. Nancy RN.
Welcome to Dr. Nancy RN. Healthy world, healthy nation, healthy you. I'm Nancy Valentine, PhD and registered nurse, and this show is dedicated to you, the healthcare consumer. And today we have a show that is on a very difficult topic for most people, because most people will not have heard of this particular disorder. But we want to talk with you about it today because we feel that even though it's considered a rare disease, it's not that rare if you happen to be someone who has this disease or if you know someone that has this disease. Our topic today is entitled Catching Your Breath, Living with Pulmonary Arterial Hypertension. And we have a guest today from the University of Pennsylvania School of Nursing who is an expert in this field, Leanne Matura. And I am going to introduce Leanne in a few moments, but I want to tell you a little bit about this topic so we can open it up for your interest. Pulmonary arterial hypertension is really a devastating disease that affects primarily young to middle-aged women. It's a rare disease, but 30 to 40,000 people every year in the United States are diagnosed with this disease. And once treated, when it is picked up, which is one of the key points of this show, is really a longevity of living 7 to 10 years with treatment. And our goal in talking with you about this today is to really get people to really understand how to pick this up more frequently, much earlier, and that way to increase the longevity. Now, why is this so tough? Because signs and symptoms such as fatigue, shortness of breath, are similar to other common illnesses, and therefore, many times people do not get a correct diagnosis, and it can take them 2 to 3 years of going to various doctors to receive the correct diagnosis. In fact, often people do go to 2, 3, even more physicians in order to get that diagnosis nailed down. It is also a very expensive treatment regime. It can cost at least $100,000 a year to treat this disease. And so if you don't pick it up sooner and you're picking it up later, it costs even more than $100,000 because the treatment is that much more intense. So people are often misdiagnosed and they really do not get the treatment that they need in a timely manner. So Leanne is going to really help us today to understand that you need to listen to your body and find the signs and symptoms that may relate to this disorder, because they can be elusive. So we're going to help you to pay attention. The second thing that we're going to talk about today is self-advocacy, and that's getting the correct diagnosis. And that if the symptoms that we will talk about in detail today do not improve after your initial treatment within about 3 or so months, you really need to move further along and get a consultation with a specialist. Then what we want to talk about is if you were diagnosed or someone that you know is diagnosed, getting treatment is critical. It has to be rapid and it has to be really the right treatment, because the quality of life through intervention with symptom management, which Leanne is an expert in, is really key to your quality of life and your treatment outcomes. So I know that was a mouthful in terms of the introduction, but it is a difficult disease to really understand. And I'd like to introduce our expert today, Dr. Leanne Matura. Leanne hails from Texas. She has a bachelor's degree, a master's degree, and a PhD from Texas Women University, and has spent much of her career in Houston, Texas. But lucky for Philadelphia, 2 years ago, she was recruited by the University of Pennsylvania School of Nursing. And she is an assistant professor and teaches undergraduate school students in the School of Nursing, and her course focuses care of the older adult. So she has had a lot of research opportunity in dealing with arterial hypertension, pulmonary arterial hypertension. That is her area of focus of her research, and that is why she is such an outstanding expert to really train us. So I want to introduce you to our audience and to welcome you, Leanne.
Thank you very much. I'm very happy to be here.
Very good. Thank you so much. I wanted to say that, when I was learning about this particular disease, which even as a nurse, unless you are working in an intensive care unit or some other intense pulmonary setting, a lot of nurses and physicians would not understand this either. So, I had to do some reading and background review, but I wanted to say that one of the best ways of really becoming conversant on this was to read an article that Leanne has published just a couple of years ago in a very prestigious British Journal of Cardiac Nursing entitled Pulmonary Arterial Hypertension, an Overview. And I think that, we're inviting you to help us, by giving us some of the key points that you wrote about in your article, Leanne. And I think a best place to start is, you as a nurse, you've been a nurse in cardiac settings. You are a advanced nurse practitioner. How did you even, find this an area of interest in your own professional practice?
Right. So when back in the 1990s, when I was practicing as a staff nurse back in Texas, they were doing some clinical trials, which are experiments where they're looking at potential treatments to help people with pulmonary arterial hypertension. And I would see these young women coming in, and they were so short of breath and so ill, and at the time there weren't any treatments for them. So that was, sparked my interest in the beginning. And then as time went on, when I started more research, getting into my own research, this was just an area where there just wasn't a lot as far as symptom management and those kind of things.
Now, in terms of the treatment, if they had clinical trials in the 90s, what would have been the advances just in the medical treatment of this illness?
So right now there are what they call 8 approved therapies for pulmonary arterial hypertension. You can imagine when the first one came along in the 1990s, that was the only one they had. So they are making a lot of advancements. Some of these treatments, though, are continuous intravenous therapy, so they can be very complex treatments, and as you had mentioned before, very expensive treatments too.
Okay, but this disease obviously has been around a lot before they started doing the clinical trials in the 90s. Were they, what's the history of really understanding this illness? Like the epidemiology, was it constantly missed for generations?
Right, because this is considered a rare disease. There wasn't a lot of initial research, and they weren't really good at diagnosing this. One of the problems with this particular disease is that it can look like other things, especially early on. So you come in, you're a little bit more fatigued, you're feeling tired, you're short of breath. And so you can imagine these are, women in their 40s and 50s that have a lot going on in their lives. So a lot of time they'll get diagnosed with things like asthma, maybe congestive heart failure, and put on therapies for those particular diseases, which don't work for pulmonary arterial hypertension. So these aren't effective. And as those years go by, when they're trying to get diagnosed, their hearts are actually weakening and becoming much worse.
What is the actual cause of this illness? Let's sort of go back to the beginning. Do we know what really causes this? It's a rare disease, so what are those factors that are contributing to some people getting this?
Right, so in about half of the cases, so in about 50% of the cases, we don't know. What's what we call idiopathic, so we really do not know what's causing that. There are some other familial type of disorders that have a genetic component to it. So then usually that one we can find fairly easily because someone in the family has had this and they're able to get treatment early on and get tested. But there's also associated disorders, like people with HIV, things like scleroderma, congenital heart disease. Some of that can actually over time cause pulmonary arterial hypertension.
As a secondary effect of that disease. Okay, so if you know in your family that someone died of a pulmonary related disorder, that could go back a number of generations. Would that be like an alert I mean, they may not have died of pulmonary arterial hypertension. It could have been some other pulmonary problem. But since this is so elusive, that would seem to me like something that a family should pay attention to.
Definitely, and that would definitely be something that you would want to let your physician, your primary care provider, know that that people or someone in your family had died of some kind of disorder, and so that could be a clue that you may need to get tested for this, especially if you're starting to show signs and symptoms.
That's a good point, because I don't know, correct me if I'm wrong, but it seems to me that when you fill out those usual face sheets when you start with a new physician or group practice, it asks you if someone in your family died of cancer or heart disease. I don't remember anything being there about pulmonary disorders. Is that generally asked?
And you're probably right. And that's what, that's a very good point, is that a lot of times they're really focused in on things like cancer and cardiovascular disease, but they may not pick up this pulmonary arterial hypertension, which can affect your heart too. I mean, you get problems on what we call the right side of the heart. So you're right. We don't actually really ask that specific question.
So a tip may be that if you have any knowledge that someone in your family had a pulmonary, meaning breathing, anything related to their breathing, that was really their primary problem, or that's for the best of your recollection what they died from, you may have to really volunteer that information to your primary care provider or group practice that you're working with.
Right, no, that's a very good point, yes.
Okay, definitely. So since we don't know, other than there may be a familial attachment, some genetic markers that are really not understood at this point.
Correct.
Or if you have other very serious illnesses like HIV, that would be, again, a red flag for your treatment team to really rule this out if you started having such symptoms as chronic fatigue and shortness of breath. It sounds like the shortness of breath is a real clue.
Yes, it is, definitely. Yeah, because fatigue is, again, one of those elusive kind of symptoms that could be a lot of different types of disorders. So yes, and definitely, and I think that as a group that there's been more trying to get the word out to physician groups that if they are treating things like HIV or these scleroderma, that maybe screening patients, listening to their symptoms. And again, hopefully through the show, we can actually have people that have those disorders, that they're paying attention to their body so that they can alert their physician when they're having these kind of issues.
Right. I think most people have heard of HIV and have some cursory knowledge of that, but I don't know that everyone's heard about scleroderma. Can you just give us a really short overview of that so people would understand that this could be a secondary problem? Right.
So with scleroderma, the people tend to have problems with the collagen in their different joints and their skin, and so they develop issues around that. And so a lot of times rheumatologists sometimes will treat that particular disorder, or you might have primary care, again, depending on what part of the country you actually live in.
And this can be another sort of progression in the illness, that you really have these cardiac problems. And again, it's not really understood how these things all link up together.
Right, and that's what they're hoping to get at. And why do certain people with HIV, would they actually develop pulmonary arterial hypertension? We just don't know at this particular point.
So tell us, if our goal was to say, it's rare, you could have shortness of breath, you could have chronic fatigue. Are we leaving anything out, or are those the two symptoms?
No, there are quite a few more. People could actually develop chest pain. They could have problems sleeping. They could have problems, they could have shortness of breath, not only just with exertion, but at rest, maybe at night, those kind of things too. Another thing too, and this is usually once the pulmonary arterial hypertension has progressed, they could actually have some dizziness and actually some what we call syncope, but it's actually fainting. But again, hopefully before you get to that point, you've already been to someone and had a diagnosis, because that's usually later in the disease.
So that would be hard, for people to really rule out for themselves. That's really obviously why you need to be, seen and evaluated. But are these the kind of symptoms that people tend to sort of say, I think I'll wait and see if it goes away?
I think so. And fatigue, we can explain a lot of that away with just whatever's going on in your life, not getting enough sleep, things like that. Also, with the shortness of breath, when you know, exertion. As we get older, you know, you start thinking, well, maybe I'm just getting older. But these are things, and so people will tend to back off on their activity level so that, you know, they're not exerting themselves and may not really realize that there's something really going on that could be devastating and life-threatening to them.
Right. But you said that a lot of the people that really suffer from this are younger women in their 40s and 50s. That you said that was basically the age range.
Yes.
So this would be a little bit different than just the older adults having some of this. Not that you couldn't be older and have this, but the likelihood seems like it decreases with age rather than increasing with age.
Well, I also think that, you know, some people actually, they're dying too, so they're not reaching to be actually older adults. I mean, in my research, you know, we do have several people that have, you know, in their 60s, 70s, 80s. So, you know, hopefully with treatment and therapies that, you know, we will have, hopefully they'll be cured someday, but hopefully we are able to see them living into their older years.
Right. But, you know, in terms of this early diagnosis, aren't there differential tests, meaning that there are tests that are sort of the usual tests that would be done to rule this out? So, or is that not being done until much later, after the symptoms don't seem to be going away and you may be on to your second or third consultation? And then there are certain tests that are done then. What are they?
Right. So, you know, probably initially, if you go in and there, you know, people are thinking maybe it's something like asthma, you know, you might have, you know, you could just have someone put you on maybe some type of inhaler therapy. They could order some pulmonary function test. But really what's going to start getting at this is doing an echocardiogram, which is like an ultrasound of your heart. And that's still not diagnostic, so you still can't have, you know, this ultrasound done and basically say you have pulmonary arterial hypertension. But on those type of tests, if they saw something abnormal, the way that we actually get a definitive diagnosis is by doing what we call a right heart catheterization. So it's an outpatient procedure where they go in and they actually put a small catheter, thread up this wire into your heart so that we can actually measure the pressures in your heart, and that's how you actually get the ultimate diagnosis.
Right. But since those tests are very aggressive, and you would not necessarily do that early on with someone that has some of these symptoms, it seems like it's the treaters are on the horns of a dilemma, as well as the patient trying to be conversant about, you know, I have these symptoms, I'm short of breath at rest, I can't sleep, you know, really being very articulate and very clear about what your symptoms look like and feel like. It seems that you would want to spend some time before you would intervene with those kinds of tests. So we were talking earlier on that if people are having asthma and they're not responding within some kind of reasonable period of time, you said, you know, approximately 3+ months, would they then move to those tests, or would they try other things in the meantime?
So I would hope that, you know, this would be something that they might be thinking about, pulmonary arterial hypertension. And the other thing is too is that, you know, if the symptoms aren't getting better, but also if they're getting worse. So if they're definitely getting worse, then I think that hopefully the patient and the provider are thinking that maybe we do need to do some more extended testing here.
Okay, so that's a very good point. It's not just the duration, but it is the worsening.
Yes.
So this is getting back to the listening to your body idea, that you really keep some notes. You know, that's also very helpful to the treatment team. If you can really say, I've got these problems and this is what it occurs, these are the hours of the day that it occurs, this is the duration, this is how long it lasts. Anything that really gives that detail sounds like it would really help the treatment team.
Or what makes it worse. So, you know, with shortness of breath, are there, you know, is there certain activity? You know, if just walking around your home, you know, carrying a laundry basket, now you're really short of breath, and that is definitely something that, you know, you need to alert someone right away.
Right, right. Okay, so moving on to the actual diagnosis. Okay, say someone, whether it's earlier or somewhat later in the game, does get diagnosed with this illness. Then what is the next step? How does the treatment actually roll out from there?
So there are guidelines out there for the treatments, and so with these guidelines, you know, they'll see how severe your disease is. So hopefully they're catching it at an earlier part in your disease trajectory, so that oral medications are what they can use at the beginning. But there is some research showing out there that people are getting referred like later on, and so at that time they may have to use multiple oral medications, or even potentially these continuous IV medications.
And what do these medications actually do to the body? How do they act?
So the way with pulmonary arterial hypertension, what happens in the pulmonary vessels is that you get vasoconstriction. So it constricts down so the blood can't go through as easily. So that's why you get the hypertension there. And then also there's what they call some remodeling of the vessel wall. So it actually gets thickened and actually gets a little bit larger in there. So again, the blood can't go through as easily. So these medications work to combat that. So basically to vasodilate, to open up those vessel walls so that the blood can get to your lungs and to the rest of your body.
Okay, so once people are on these medications, whether it's early on and they're taking oral or somewhat further down the line where they're taking them intravenously, what would be their relief? I mean, what do they actually experience?
So the way that we so their symptoms. So hopefully they're able to. One of the tests that they do quite frequently are what they call a 6-minute walk distance. So they'll do those in the hospital. So just how far you can walk in 6 minutes. And so people on these medications, as they start improving, will be able to walk further without feeling short of breath, without having their oxygen levels go down in their blood. So that's how they'll know that they're better. So basically, their shortness of breath should really improve, and then hopefully their fatigue also will improve.
And so the amount of medication that a person gets is really dependent on this ability to walk better without symptoms.
Right.
That's sort of the measure of success.
Yes.
And so you could be on a little bit more or a little bit less depending on how you're doing. So it's customized to each patient.
Yes, it is.
Okay. Is that a lifetime regime? Will they be on these drugs for the rest of their lives?
Yes, at this particular point they will be, and they may have to change as time goes on, whether there's new medications that are going to be better, easier. I think the hope is that we obviously have a cure, but until that point, medications that we're not having to use the continuous IV, because that's very complex, very expensive treatments. And so patients, if that's what they need, obviously it improves their symptoms and decreases their mortality. But
and can this be done at home? Can these IVs be administered at home under supervision?
Yes, they are. And actually patients and their family members are trained to do this because it's around the clock. So they're the ones that become very expert at doing this.
So this really changes your quality of life and in terms of how you can even manage your day-to-day affairs. So that is your area of expertise. Tell us about that. How are nurses in particular, but the team in general, helping people to cope with this?
So I think that, when they come in and when you're actually selecting treatments, so, knowing people, whether they're going to be able to actually, manage these IV treatments. But I think that they're really good at, the whole team is really good at listening to patients and to developing a personalized and individualized type of treatment regimen. And if people are on oxygen therapy or something like that, the nursing staff is really good about, making sure they have enough supplies that they can travel. People travel on airplanes and do those kind of things. So really trying to maintain that quality of life and, that sense of, trying to be normal and trying to live day to day, even though you do have this disease.
Right. Not that everyone that has this disease is a younger woman, but I think in the profile that you were sharing with us earlier, these people have growing families in many cases. They have a real need to live. Their role in their families, is really pivotal. So in working with clients such as these, what do you find are the biggest challenges that people have to face?
Well, probably early on. I think that there can be a lot of frustration that it took them 2 or 3 years to get to this diagnosis, and they feel like, they could have done things differently, could have pushed harder. So I think that sometimes there's a little bit of that frustration at first. But I think once they get the diagnosis and that they find out there are treatments and therapies, and the other thing is that they network among each other and find out each other's stories and are very supportive. So I think once they get over that, frustration from not being diagnosed to getting on therapy and feeling much better, then their quality of life does start improving.
But let's go back to those lessons learned, in those 2-3 years that it typically takes to get diagnosed. What do you think could have been done differently?
I mean, I think everyone has their story about this, but I think that, when their symptoms aren't getting better on these particular medications or whatever treatment regimen that they've been given, that to push forward and saying, I'm concerned that this is something different or something more. And especially if it's getting worse and you're on a particular therapy, then I think that's definitely a sign that there may be something else going on there. So again, kind of pushing forward, being an advocate for yourself. I think families are really good about, getting around the person and, going to these visits with the physicians and actually, saying, this doesn't seem like it's working. Could there be something else going here? Do we need to go somewhere else to look for a different treatment or a diagnosis?
So do you find that that's because the physicians aren't listening carefully enough, or do you think that it's because they don't have a lot of time with patients? Why do you think that it would take that much self-advocacy? I mean, most physicians really do want to do the right thing. So, I mean, what sort of in this case gets in the way?
I think what happens with this is because it is a rare disease, and I think that they definitely, and I think they were trying to find the best therapy and trying to diagnose. And, if you're in an area and, these pulmonary hypertension centers are not located in every community. And so, maybe someone that's in a rural area, would be very difficult for them to maybe come here to Philadelphia for care. So I think that basically it is rare and they may not know very much about it, but I think that also you have to think about where else could they go to actually get this type of diagnosis and treatment.
Right. So I think this is a really good example of it's not a fault-finding approach. It's really about how to collaborate. And I think what Leanne is telling us is that if you have these set of problems, or if you know someone that does, or if you're the family member, you do have to practice what a lot of this show is all about, and that is how to have those self-advocacy skills, how to say, I don't feel I'm getting better. What else, as you were just coaching us, what else can I try? Is there another place, outside of our community where I could seek, a second opinion? I think that the physicians will be very supportive of that. Often, like you say, if it's a rare disease, they're not necessarily thinking of that. Only you are thinking about it because you are suffering with this. And so I think it's creating that dialogue. And I think that a physician then would be very helpful, or a practice would be very helpful in helping you to take that next step. So the lessons learned by people that Leanne has worked with and has talked to is that they wish they had pushed harder. A little late when it's you, but this is why we're having these shows, because we want to communicate to others so that other people can learn from those lessons and they can push a little harder for themselves or other people that they know. So that is really positive. So they said that they would rather have gotten treatment earlier. But once they get treatment, they feel somewhat reassured, and the way the team works is really to try to customize the treatment, try to make it very user-friendly as much as possible, try to let people have the quality of life and keep the quality of life as long as possible. And I think that is extremely important, because these people have a life-threatening illness. It is not reversible, it is treatable, but it's not going to reverse the basic conditions. So the name of the game here is to get as much life as possible and a good quality of life. When you think about your journey through being involved with this, what would you say in closing is what really gives you the most satisfaction in dealing with people that have this problem?
Again, being a nurse, so hearing their stories, listening to their journey through life and through having pulmonary arterial hypertension, and hearing the stories when they actually do get better, because they can with therapy, they can actually get better. They have a lot of hope. They have a lot of great stories, and I've been very fortunate to be part of their care and their lives.
I think that's wonderful. Well, I think, the title of our show today has been Catching Your Breath, Living with Pulmonary Arterial Hypertension. And I think, again, we often talk about the big diseases, heart disease, cancer. This is a rare disease, but it's not rare if one of the 30 to 40,000 people happens to be you or someone that you know and love. So I want to thank you, Leanne, for being with us today.
Thank you.
For sharing your knowledge and expertise. I think the undergraduate students at the University of Pennsylvania are very fortunate to have you as one of their instructors, and I think that you've done a great public service for us today, and I want to thank you again for being with us.
Thank you. I was very happy to be here.
And thank you for listening, and have a wonderful day. I hope you enjoyed our conversation today and that the information will help you in meeting your health goals. Catch this program and other conversations on the website, drnancyrn.com. Or you can write to me as well. I welcome your comments and feedback. Thank you for listening, and join us again. And remember, with health, all things are possible.